Nasogastric Tubes, Implications and Insertion by Courtney Isaacs and Mara Sullivan.
Implications for NG tubes are to remove fluid, blood, or gas from the GI tract, gastric decompression for conditions such as pancreatitis, prevent digestion or absorption of poison, medication or artificial nutrition administration.
Prior to insertion, validate physician's orders, identify patient by using name band and having patient state name and date of birth, assess GI function, patency of nares, gag reflex, and risk for aspiration, assess INO, lab data, and current IV fluids, and gather equipment and provide privacy.
Equipment to be used will include water-soluble lubricant, tape, safety pin, and rubber band, NG tube, Levin or Salem, towel, tissues, and emesis basin, tongue blade, cup of water with straw, 50 milliliter catheter tip syringe, clean gloves, suction tubing, and a source of suction.
Insertion of the nasogastric tube. Explain procedure to client. Perform hand hygiene and don clean gloves. Position client's head at 45-degree angle or higher. Assess nostrils and select most patent nostril by having client breathe through each one. The nostril with the greatest airflow should be chosen to insert tube. Place towel over patient's chest, emesis basin, and tissues within reach, and establish a cueing signal with patient if procedure must be stopped momentarily due to gagging or discomfort.
Measure tube from tip of patient's nose to earlobe to xiphoid process of sternum, and mark tube with tape or permanent marker. Coil end of tube over fingers to make tube more flexible. Lubricate first 4 inches of the tube with water-soluble lubricant. Oil lubricants can cause respiratory complications. With the head slightly extended, carefully insert tube through nostril to back of throat.
Aim tube toward the ear on the same side and downward toward the nasopharynx. Have the client flex his or her head forward to prevent the tube from entering the trachea. Instruct client to sip water while advancing tube until predetermined mark is reached. Assess patient for coughing, difficulty breathing, or discomfort. Secure the NG tube by taping to nose and pinning to the patient's gown.
Confirmation of placement. Aspirate gastric contents with 50 milliliter syringe and check color and pH. The pH should be 5 or less, and the color should be green or clear with tan mucus shreds to indicate tube is properly placed in the stomach. Evidence-based practice determines that the best method of confirming the location of an inserted NG tube is by chest X-ray.
What do our textbooks and research tell us? According to Smith and Duell, a chest X-ray is the #1 way to confirm the location of an inserted nasogastric tube. Research states that the gold standard for confirming NG tube placement is a chest or abdominal X-ray.
Clinical alert. Coughing and choking are normal responses for some clients. Coughing, choking, and cyanosis, or the inability to speak, indicate that the tube may be in the airway. Never insert an NG tube in a client after nasal or craniofacial surgery or a hypophysectomy.